Okay, so before I enter the patient's room, I would check the patient's chart, I would check the physician's orders, I would check for the rate, the route, and the type of formula that I will be administering. I will also obtain a baseline weight to determine whether I should increase or decrease after the initiation of feedings. Then I will gather my supplies, I will come in the room, wash my hands, put on gloves. Hello, my name is Victoria, I'll be your nurse today. Can I get your name and date of birth? I will check the armband. Okay, so today I'll be doing an enteral feeding through your NG tube. Then I would raise the bed to work in height, lift the rail, side rail down, and I will place the patient in semi-Fowler's position. I will check the expiration date, and I will also make sure it's not open or punctured, and I will also make sure that it is room temperature. And then I would auscultate bowel sounds. I will start in the right lower, right upper, left lower. And then I would check the placement of the tubing. I could check by looking in the patient's chart to see what measurement they have in there. I could also look at the marked measurement on the tubing. Then I would check the gastric content residual. I would clamp this and clamp it, and I will unclamp it because I don't want to. I will pull this up, and I will just aspirate all of the gastric content before to measure. And I would check the pH of it, which it should be less than 5.5. And then I will continue to do this until I have gotten all the gastric content out. And if it is less than 250 milliliters, I would replace the content back into the tube and continue the process. If it's more than 250, I would still place the content back into the tube, but I would have to come back in about an hour and reassess. And when I come back to reassess, if it's still more than 250, I would also check for abdominal distension, and I would notify the doctor. If it's less than, then I can continue the process, but at a 50% rate than what I was initially starting with. So next, I would get this, and I would shake it, not so much because you don't want to put air on the patient's stomach, which could be very uncomfortable. And then I would remove the plunger, clamp this, and then I would just fill this up and let it flow. And I would not put it no more than 15 to 18 inches above the insertion site of the tubing. And I would just let that flow in. And I will continue to do this until I have administered the amount that was prescribed to the patient. And I'll just let it flow. And before before it gets too low, I do not want to put any air on the patient's stomach. So then, once I have given the patient the right amount, I would add a little water to flush the tubing. I would do 50 to 100 milliliters, and I would just let that flow in to clear the tubing. And then I would pull this out, clamp it back, and I would administer water to the patient between feedings or as ordered. I would leave my patient in semi-phallus position to promote gastric emptying and to make sure that the patient doesn't experience any vomit or they don't aspirate. And then I would lower the bed to the lowest position, let the bed rail up, leave the call light in reach, ask the patient do they need anything before I leave, and then I would get my supplies, and I would, of course, rinse this out, put it to the side, wash my hands, take my gloves off, wash my hands. I would leave the room. I would go document, and I would observe the patient respiratory status. I will make sure that the patient doesn't have an increased heart rate, as well as any wheezing, an increased coughing, or a decreased O2 set. I will also auscultate the breath sounds at least every 8 hours. I would also check the gastric content residual every 4 hours to make sure that the patient is tolerating the feedings. And then I will also check lab values. I will be checking for pre-albumin, albumin, and transferrin. And if there's any abnormalities in those, then I will notify the doctor. And then also I would look at the intake and output every shift, and I will also calculate what it was in 24 hours, and if it's an imbalance in it, then I would notify the doctor. I would check the weight daily, and also if the patient has an insertion site like a tube in their abdomen, I would look for any infection. I would look, so there could be arrhythmia, there could be edema, there could be warming of the skin around the incision site, and I would be looking for drainage. Okay, so to get started, I would assess any contraindications to medication administration. I would check lab results, vital signs, and bowel sounds. I will also check the site where the tube is, as well as the placement of the tube and any residual feeding. I would check to see if the medication, if it's non-liquid, does it need to be crushed or opened. And then I would check the original order to make sure that it matches the medication administration record, and I can also determine whether the pump should be turned off before or after medication administration. And then I will wash my hands, follow standard precautions. I will do the 7 rights, which is right patient, right medication, right dose, right route, right time, right reason, and right documentation. And then I would determine then I would get my medication, I would crush it, which I have already done. And then also, if it's enteric coated, extended release, or sustained release, it cannot be crushed, cannot be used. And then I will put it in the medicine cup. and I would mix it with a little water. And if I was using more than one medication, I would have to put it in a different medicine cup. And then I would gather my supplies, and when I come in the room, I wash my hands, put on gloves. Hello, my name is Victoria. I'll be your nurse today. Can I get your name and date of birth? And then I will check the armband. Okay, so today I will be doing medication administration through your tube. Then I would sit the bed up to work in height, have the patient sit in semi-Fowlers, and then I would let the side rail down. And then I would clamp my tubing. And first, before administering the medication, I would put my syringe on here. And I will put 30 to 60 milliliters of water before administering my medication to flush the tube. Before it gets low, I would also do another medication administration check to make sure that I'm giving the right medicine and dose and route. Put that in there. And then I will put 20 to 30 milliliters of water to make sure that it does not stick to the sides of the tube, as well as make sure that the patient gets all of their medicine. Okay, clamp that, and then we'll take this off. Okay, so after I get done with that, I would leave the patient semi-Fowlers. I will also determine whether I should continue the feeding. If not, I'll have to come back in an hour to 2 hours. And then I would lower the bed to the lowest position, raise the rail, leave the call light in reach, ask patient if they need anything else, gather my supplies, I'll wash my hands, take off my gloves, wash my hands, and I would document, and I would document intake, outtake, as well as the water that was given. And I would also assess the patient every 30 to 45 minutes after the medication administration to see if they have any desired effects or adverse effects. Okay, so this video is about me explaining how to set up a portable suction to a NG tube. So before I get started, I will check the patient's chart for any physician's orders dealing with the suctioning and the pressure needed for the suctioning. So I will come in the room, wash my hands, introduce myself. Hello, my name is Victoria. I'll be your nurse today. Can I get your name and date of birth? And then I will check the armband. And then I would explain what I'll be doing, which is setting up a portable suctioning to their NG tube. Then I will put on clean gloves. Then I will raise the bed to working height. I will let the side rail down, and I will sit the patient in semi-Fowler's position. After that, I will check the placement of the NG tube by checking like the measurement that's marked on there. And then I also would aspirate at least about 10 milliliters of gastric content. And then I would check the pH for that. It should be less than 5.5. And then after that, I would plug up the portable suctioning machine, and then I would get the container and the cord that's connected to the container. I would connect it to the suctioning machine. And then there's a second cord that I would get, and I would connect that cord to the suctioning machine. And then after I do that, I would clamp the NG tube, open it, put the syringe in, and I would instill 10 milliliters of air into the tube. And I should hear a soft hissing sound. And then I would clamp the NG tube back, take the syringe out, and the second cord that I had, I would put that cord into the NG tube. And then after that, I would turn on the suctioning and to the prescribed amount. And then after that, I would, if it's an emergency, you always put the suctioning on low. And then the stop clock, I would open that so it can start suctioning. And then I would have to observe the drainage that's going into the container. And then after that, I can just lower the bed to the lowest position, lift the rail up, leave the call light in reach, leave the patient in a comfortable position, ask them do they need anything, and then I could remove my gloves, wash my hands, leave the room, and go document.